Step into the realm of knowledge. Empowering doctors, advancing excellence. Where innovation meets practice. Exploring the frontiers of medicine. The pulse of medical advancement. Elevating knowledge, inspiring excellence. Your gateway to medical mastery. Bridging science and humanity. Pioneering progress, shaping tomorrow. Redefining professionalism together. Mahiyanganaya Clinical Society, in collaboration with Government Medical Officers Association of Mahiyanganaya Branch Union presents Academic Hour 2025.
Good afternoon, everyone. It is a pleasure to welcome all of you to the first session of the Academic Hour 2025. After a successful 18 sessions and a cultural event in 2024, we expect to keep up with last year's standards and make this one even better. Throughout this year, we will be engaging in more informative discussions to challenge our thinking and refresh our knowledge. I encourage all of you to participate and make the most of this opportunity to learn and grow. First up, we would like to have our director, Dr. A.M.S. Bandara, speak a few words.
Thank you, Doctor, and thank you for inviting me, all consultants and doctors and other colleagues. Actually, this is a very important event. When we see the SLMC registration, I saw that they are concerning about this professional development and skill development. In near future, it could be a requirement for the registration in SLMC. So we have started last year at the beginning. I can't remember the dates. Anyway, it is very important, and especially for the doctors who are in periphery. Their knowledge has to be updated. They have to develop their skills and current knowledge they have to gather. So this is a very important event. So thank you for organizing this event, and I express my gratitude and thanks for all the organizers. Thank you very much.
Thank you, sir, for those kind words. Next, we move on to the introduction of our speaker for the day, which will be done by no other than our esteemed VP, Dr. Prabhash Hathrusingha.
Thank you, Hiruni, for introduction, and thank you, Dr. Bandara, for initiation of first academic cover program of Mahiyanganaya Clinical Society. So as I said earlier, this is the new beginning of after 18 successful events last year, Mahiyanganaya Clinical Society, and so there are few amendments for this year program. So we'll let you know in future, and I welcome you all for the first academic cover program. So let me introduce our speaker today, Dr. Priyantha Dissanayake, Consultant Physician, Base Hospital, Mahiyanganaya. Dr. Dissanayake graduated from University of Peradeniya MBBS in 2008, and he obtained MD in 2021, University of Colombo, and after that he had his foreign training, Kalgoorlie Healthcare, Perth, Western Australia. And so I specifically asked him about can you help us doing this some tips for ECGs, because this is a very important topic for all specialities during our day-to-day practice. What are the common problems encountering ECGs, what are the emergencies, and what are the things we have to specifically focus on. So I chose Dr. Dissanayake at this event because he has very special interest in ECGs during his career, and I will show you this book. This is the ECG 70s book. I think this has been used by the undergraduates and postgraduate students for a last couple of years. So that's why I think he's the best person to do this topic today. And thank you, Dr. Priyantha, for accepting the invitation. So I kindly invite Dr. Priyantha to start the proceedings.
Good afternoon, everyone. Thank you very much, Prabhash, giving you a kind introduction. Today, we will talk about something very important, and I think all of us, you should have not the light knowledge, we should have thorough knowledge on analyzing ECG, because ECG is a basic investigation when you come when you are managing patients, even OPD, ETU, and any inpatients. ECG is a basic and it's a common investigation. So today I try to share my our knowledge regarding analysis of ischemic, especially ischemic ECGs. So so what is an ECG? So ECG is a graphical representation of electrical activity of the heart. So when we take our electrical activity into a graph, you can see this you can see this graph. So this graph contains few complexes, waves. So you can see P wave, QRS wave, T wave, and QRS complex as well. So there are some interval, PR interval, PT, QRS duration, and the QT interval. So what we are doing during ECG analysis, we are analyzing these complexes, these things. So actually ECG analysis just reading patterns. We should have some idea about some ECG patterns. So as you know, during one cardiac cycle, you get this P wave is due to atrial depolarization. If there is any abnormality in atrial depolarization, you get abnormal P. So there are few examples for this abnormal P. You know P mitrale, you get in mitral stenosis, you get P pulmonale in pulmonary hypertension. So sometimes you get abnormal P in atrial activity, right? Then the QRS complex you get due to ventricular depolarization, ventricular contraction. So normal duration, it is less than 3 small square. So usually this 1 small square is time duration about 0.04 seconds. So 3 small squares is 1.2 seconds. Normal QRS duration is 0.1 second. Normal QRS duration. So and you have ST segment, S wave, ST segment, this point called as J point, and there's a T wave. T wave is due to ventricular repolarization, and sometimes you may get U wave. You get physiological U wave due to papillary muscle repolarization, and sometimes pathological U waves due to hypokalemia. So by doing analysis of ECG, usually we can gain the clues about cardiac disease as well as pulmonary disease and some metabolic disease as well. So before going to analyze abnormal ECG, I think it is important to know about normal ECG. So if we see ECG, we want to say abnormal, we should know about, you should have some idea about normal ECG. And I want to say that it is very difficult to find normal ECG when we are doing all ground. Even in the clinical practice, it is very difficult to find a normal ECG, but I am describing here. So there will be some sort of abnormality in ECG. So in standard ECG, you have 12 lead. Those are 6 limb leads and 6 chest lead. Limb leads lead 1, lead 2, lead 3, AVR, AVL, AVF, and the V1 to V6 chest lead. So why we are taking 12 lead ECG instead of taking single lead? The reason these 12 lead represent different areas of the heart. So if you take a standard 12 lead ECG, so you can actually see the almost whole heart electrical activity. So that's why we are taking 12 lead ECG. So different lead represent different areas of the heart. So normal ECG usually, because sometimes we take ECG by doing placing switching off with this limb leads, like if we want to take ECG, we are putting one electrodes to the left hand, to the other right hand. Sometimes we are switching off these leads. So then we have to differentiate whether this ECG is really normal or is there any technical error. So here we can see normal ECG, all complexes are positive except in 2 leads, that is AVR and V1. You can see all complexes are, that is QRS complex lead 1, lead 2, lead 3 positive, and the AVR, that's why I told you that this is actually, I downloaded this normal ECG from the internet. So it is very difficult to find normal ECGs. Usually AVL also positive. Usually you get the negative waves in AVR and V1 because those lead AVR and AVL looking away from the cardiac electrical activity, because it is going away from the heart. But in case if you get AVR positive AVR, then you think whether this is switching off of this limb leads. And the what I'm saying that, and other normal features, you can see V1 to V6 progression of R wave. So if progression of R wave, so in normal person, where do you get tallest R? In normal person, where do you get tallest R? Is it V6, V1 or V5? You usually get in normal person V4. V4 because it is the lead very close to the heart. V4, that is apex is located at the V4 lead, where V4 lead we placing the mid-clavicular line 5th intercostal space. So you get tallest R in V4. If there's a large R in V5 or V6, that means the heart has shifted to the left side. That means there's a left ventricular hypertrophy. And the if you get if you want to see the electrical activity, the atrial activity, the best lead is to see is V1, because the V1 is the lead that near to the atrial activity, atria. So you initially you look at the V1 P wave. If not, look at the inferior lead, because part of inferior wall is formed by inferior leads, lead 2, lead 3 and AVF. Here you can see very nice P wave, but when you go to lateral leads will not record P wave properly. V5, V6 you can't see, barely you can see this P wave. So that's why we are taking 12 lead ECG. So each and every lead will not record these each and every complexes. So for if you see electrical activity in specific phase, you have to see that specific lead. Okay. So, and before reading, actually another thing, we have to see the calibration of this calibration of ECG. So this is the calibration lead. Usually it is 10 millimeters per milliwatt. This is the calibration. This is 2 large squares. So if the calibration is low, if it is 5, you get small voltage complexes, small complexes. So there are some condition you get small QRS complexes. What are those? So small QRS complexes you get. in pericardial effusion, there's effusion around the heart, you get small complex where you get tachycardia. In obese people, because of fat layer, you get small complex. Any other condition? Hypothyroidism, so myxedema, you get small complexes, but where in hypothyroidism you get bradycardia, in pericardial effusion you get tachycardia. So another thing, the speed, usual speed is 25 millimeters second, so per second there should be 25 millimeter, that is 1, 2, 3, 4, 5. Right here is heart rate is around 60. So it is important to see the calibration and speed. Sometimes we are misdiagnosing these things if we not check this calibration and the speed. So ECG analysis. Before analysis, actually, if you take ECG into your hand, you are taking the responsibility of a patient life actually, because this we have to give a proper diagnosis. If a patient comes with chest pain, we take ECG, and if you are taking to the ECG to your hand, you are taking the responsibility of the patient. So otherwise, patient will die in few minutes or 1 or 2 days later, because you have enough experience on this. People come to the ED or the hospital or PP, come with chest pain or epigastric pain. We take ECG and say normal, and we'll go home, readmit or will die at home. So this is very common scenario. So that's why I'm taking, if you take ECG to your hand, you are taking you hold the life of a person, right? And the other thing, ECG analysis, there are 2 types of analysis. One is, that is clinical ECG analysis, and another one ECG, just ECG analysis. So if you are taking, usually when I take a ECG, I need a history. So without history, we can give a diagnosis, but it is not the clinical diagnosis. So there is 2 different things, so then these are actually not in the book. The clinical diagnosis of ECG and the just ECG diagnosis. So the clinical diagnosis would be different from ECG diagnosis. So it is very important to get the proper history. If a patient comes with chest pain, we see whether this could be in mind acute coronary syndrome or something else. The history is important, otherwise we can't come into make a clinical diagnosis. So when we analyze, so there's a 2 things, ECG pattern recognition. So looking at ECG, we can say this is this. So even far away we can say this is this. And other things, sometimes even we can't say what it is. So then we have to analyze it systematically or comprehensive ECG analysis. So what is the most striking feature here? This ECG. You know, it's looking at this ECG, you can see some more striking features. So we don't, here we can go with this most striking feature. It is ST depression. There is a significant ST depression. So then analyze from there. ST depression, you can see anterior lead. Here V3, V4, V5, V6, as well as high lateral lead 1 AV, lead 1 and inferior territory lead 2, lead 3 AVF. You can see some widespread. What I am calling this is widespread. It is not located to one coronary artery territory. It is located to, it is this ST depression you can see in different coronary territory, that is anterior territory, inferior territory, high lateral. That's why I am telling this is widespread ST depressions. And when you carefully see, so you should have some knowledge. If you see ECG with widespread ST depression, you have to look at AVR. So here you can see ST elevation in AVR. So this is, so then we have diagnosis now. AVR ST elevation in mind. Right, where is the occlusion? You get in left main coronary artery occlusion. That is actually critical occlusion, otherwise patient will die. If it is a proper left main coronary artery occlusion, patient will not come to take this ECG, right? It is a critical occlusion because LMC, if there is occlusion at an LMC, patient will die. And so that is one way of analysis. That is just we go with this more striking feature. The other way, so if we can't find proper diagnosis, then we analyze systematically. We can take time from in this way: the rate, rhythm, regularity, axis, and then the complex and intervals. We can analyze in this way. It takes time, but finally you can come into a diagnosis if you analyze this way. So rate is important. If a patient come with ECG, you see a ECG with heart rate of 30, what's the diagnosis? Heart rate is 30, what's the diagnosis? What could it be? The first diagnosis should be complete heart block. Because of that much of bradycardia, it is critical to have, complete heart block. That should be the first diagnosis. And it could be sinus bradycardia, right? It could be nodal bradycardia. Whatever it is, the first one, that is complete heart block, very important. So when you are telling me that the heart rate is this much, I have some differentials. So first differential is complete heart block. So I have the other differential. So then I am going through the direction. If it is complete heart block, I am asking, can you see P wave, right? So if there is no P, it's maybe nodal, right? So in that way we can. So rate is important. If heart rate is 100, it is tachycardia. So there are two types of tachycardia. It is narrow complex tachycardia, other one broad complex tachycardia. Then we can analyze in that way. So then the rhythm, usually rhythm arise from sinus node. So if you are saying it is, what are the rhythm you know? Yeah, we know about sinus rhythm. We say always it is in sinus rhythm. Sinus rhythm means the rhythm starting from sinus node. So then if the rhythm starting from sinus node, we don't want to worry because the sinus node is functioning well. So I know that patient is not going to die soon. The patient in good rhythm, this sinus node is working, right? If sinus rhythm. So what are the other rhythms? Atrial ectopic rhythm. So instead of this SA node, if the rhythm starting from here like atrial ectopic rhythm, so then you will get a rhythm P followed by QRS complex, but different from sinus rhythm. So then you should have some idea about what is the pattern, P wave pattern in sinus rhythm. Usually it is upward, P wave upward all leads except AVR and sometimes V1, that where you get negative P in sinus rhythm. If it is atrial ectopic rhythm, so you may get some sort of different P waves from this sinus rhythm. So then you can say it is atrial ectopic rhythm. If it is nodal rhythm, the rhythm starting from here, sometimes you may see P just before QRS complex or just after QRS complex or no P. Or it may be a ventricular rhythm. It should be the broad complexes. It should be a ventricular rhythm as well. So there are some other type of rhythm as well. Sometimes we are telling that not in sinus rhythm, like in atrial fibrillation, we are not saying that it's a fibrillatory rhythm. We are saying that it's not in sinus rhythm. So I know that. So sinus node is not giving the rhythm in this case, right? So if in other cases if we can't find the rhythm, we are mentioning the rhythm, right? Okay. So what is the rhythm here? It is nice ECG strip with some P wave followed by QRS complexes. There are some P waves. This could be normal sinus beat, but this is abnormal P. This is the one that I told you. This is ectopic P, and it is conducting through the AV node, giving rise to this narrow complex QRS complex. This is sinus, this is sinus, this is sinus most likely, and this P is abnormal. This P is abnormal. This P is abnormal. This P and this P is similar, so it must be arising from same focus, right? This one is abnormal P. So there are some abnormal P's. Right? So there are from these P's are from multiple foci. So here, this is an ECG with MAT, multifocal atrial tachycardia. So there are multifocal atrial tachycardia, you know, that is the rhythm is giving from different part of the atria. So multifocal atrial tachycardia, you can see people with pulmonary disease, especially COPD people, when these patients come into the ED or ETU. If you take ECG, you can see the various sort of atrial activities. This is map. And the other important thing is axis. Normal axis AV is -30 to 90. So how do you know whether this axis is left axis deviation, right axis deviation, or normal axis? How do you know? So usually when I read ECG, I read only 3 leads to find the axis. That is only, so initial part, lead 1, lead 2, lead 3. I am looking at only those 3 leads. By looking at these 3 leads, you can say whether this is, what is the axis, right? In normal axis, lead 1 positive, lead 2 positive, lead 3 can be positive or negative. In left axis deviation, lead 1 positive, lead 2 negative, lead 3 negative. So right axis deviation, left L1 negative, this one positive or negative, this is positive. So we'll see how it happen. So when we place our leads, so here you have lead 1, here you have lead 2, here you have AVF, you know these things, AVF, and here you have lead 1 and here, sorry, AVL, here you have lead 3, here you have AVR. AVL, lead 1, lead 2, lead 3 and AVF. So normal axis here, we'll see this is normal axis -32 plus 90. We'll see axis now here. It is marginally left. If it is going beyond this, it is left axis deviation. When we take ECG, so perpendicular lead to the AVL is lead 2. So where you get positive and negative wave, it is isoelectric. So, and if the axis is deviating to this side, so now recording this is lead 2, it is not perpendicular, the angle is more than 90, it should be a negative lead, right? So then the left axis deviation AVL positive, lead 2 going to become negative, and lead 3 definitely negative because it is away from the axis now, away from this axis, away from this lead 3 lead, away from the lead 3. So that's why I am telling if sorry. Stuck with that. That's why I'm telling that when the lead 1 is positive and lead 2, lead 3 is negative, that is left axis deviation. And you can go through the right axis deviation in the similar way, and the normal axis this way. So the only you need actually 3 leads to differentiate axis. That is important. If you have left axis deviation, that's mean the left bundle branch has two fascicle, one is anterior fascicle and other one is posterior fascicle. If you get left axis deviation, that is anterior fascicular block, and if you get right axis deviation, that is posterior fascicular block. The fascicular block will be indicated by this axis deviation and marginal prolongation of QRS complexes. So the other thing, when we are analyzing systematically, we have to go through these each complexes and the duration to see any abnormalities. You know, normal duration of this PR duration, normal 3 small squares to 5 small squares, and the QRS duration I told it is 0.1 second, and the QT interval it is corrected 0.44 to 0.46. So looking at this ECG, so what can you say? Because I'm just focusing about the analysis of ECG, that's why I took these ECGs. Looking at this ECG, what can you say? It is broad complex. That is the most striking feature, and regular, right? So broad complex regular tachycardias, there are some other features as well. The most likely common diagnosis is VT, ventricular tachycardia. It is not in sinus rhythm. And so if you can't, you have to get the diagnosis. You have to go manage this analyze systematically. The first thing, axis rate is around 100. Rate rhythm, we can't see P waves, it's like ventricular origin. Regularity, looks like regular. Axis, V1 negative, lead 2, lead 3. This is some sort of from different focus. So anyway, it looks like right axis deviation, and the complexes broad. So it looks like VT. If you see broad complexes, what are the differentials? If you see broad complexes, you have only 4 things. If you see broad complexes, you have only 4 things. So the diagnosis is very easy. One thing is ventricular origin, another one bundled branch block, another one hyperkalemia. Hyperkalemia, you get broad complexes due to sine wave and the prolongation of S wave, hyperkalemia. Another one, only 4 things, WPW syndrome. So if you see broad complex, check whether, what could it be? Is it VT, bundle branch block? Then we have to think about the other features, hyperkalemia or this WPW. And we'll go with some interesting ECG. So this patient, 56 years old man, presented to the ED with central chest pain for 1 hour. History is suggestive. State the complete ECG diagnosis. What could it be? Most striking feature here, diagnosis when we are analyzing. We don't want to go to systematically. You can see most striking feature, ST elevation. So in which lead? In anterior territory V1 to V6, ST elevation, and lead 1 AVL. State a complete ECG diagnosis, acute anterior stemming, acute extensive anterior stemming, pericarditis, anteroseptal stemming. So if you are telling STEMI or whatever acute coronary syndrome, the STEMI especially, you have to tell few things, you have to mention about few things. One, whether this is acute late presentation, recent or old STEMI. Time duration is important. Looking at ECG, you can say the time duration. Whether this is within before 12 hours, 12 to 24 hours, or after that, we can say it. It is important. And the territory, which coronary artery, what is the culprit coronary artery? Whether this is anterior descending, is it left circumflex, it is right coronary artery. So what is the culprit coronary artery here? There is an involvement of anterior territory, that is V1 to V6, and the high lateral, lead 1 AVL, those are high lateral. So here is the culprit coronary artery. This is the coronary circulation. You should have some knowledge about the, when you are analyzing ischemic ECG, you need to have coronary circulation and anatomy knowledge. So anterior descending here, left circumflex, this is right coronary. So this high lateral, it is very important and you should know, because you can miss this. High lateral, the diagonal, the first septal perforator, then the diagonal branch. This is a branch of anterior descending coronary. So if there is occlusion here, you can get high lateral STEMI, right? And here there is a ischemia to this area as well as this very proximal LED occlusion. So this patient, this ECG, STEMI is due to very proximal LED occlusion. So we'll go to the next one. 45-year-old man with, present to the ETU with severe central chest pain and sweating. Again, history suggestive. State complete ECG diagnosis. You can see, again, the history suggestive, you can see ST elevation, but it is, you can see some abnormality here, isn't it? So V1, you have tall R. Usually you do not get tall R in V1. There's a progression of R wave from V1 to V6. So you have tall R. What are the conditions you get in tall R in V1? So this is the way actually learning ECG, and because we should have knowledge and we should have some images on your mind, because this ECG is reading is pattern reading. You should have some idea about this pattern. So what are the causes for so if you see AVR, ST, the R in V1, you have tall R, so there are some causes. So then you are looking into, you are going that way. What is that? Right bundle branch block, you get tall R in V1. Some other causes. So pulmonary hypertension, again, that is due to right bundle branch block. Any other causes? Posterior MI, you get V1 or V2 tall R. Any other cause? WPW syndrome type A, you get tall R. Any other cause? So those are some causes for tall R in V1. Right. So here, this is in sinus rhythm. You can clearly see P wave, and there is a QR pattern in V1 and slide is in lead 1 and V6. So this is right bundle branch block. So this is anterior STEMI complicated with right bundle branch block. If you see ECG with right bundle branch block, these are the clues that I am going to say actually. So if you see ECG with right bundle branch block, what else you are looking for? For what you are looking? What else you want to see? You see ECG with right bundle branch block. Definitely you have to see the axis, right? So why? The previously I told that if you have left axis deviation, that is anterior fascicular block. So here axis, lead 1 positive, lead 2 positive, lead 3 positive, negative or isoelectric, this is normal axis. If you have left axis deviation, so right bundle plus anterior fascicular blocks, there are 2 fascicle block, remaining only 1 fascicle, that is posterior fascicle. So we can't say the behavior of this ischemia. Patient can get any time the ischemia to the remaining fascicle, that anterior posterior fascicle, and patient can have complete card block and arrest. So then those patients we can monitor closely. Recently also I saw one patient in the medical ward with the right bundle branch block and the some deviation, so it is a late presentation, but there is a high chance of having cardiac arrest due to complete heart block. We can't say the behavior. So axis is important if you see right bundle branch block, and the other thing PR interval. In trifascicular block, but you get prolonged PR. So look at the PR as well. So right bundle branch block, axis deviation and PR interval. If you have prolonged PR, that is mean trifascicular block, impending complete heart block. Right. So this is anterior STEMI with right bundle branch block. Anyone knows how to differentiate right bundle how to diagnose right bundle branch block? So if not, I think it is later you can read on. These are actually simple thing. And this patient has anterior STEMI. You get anterior STEMI due to left anterior descending artery. So this LAD supplies anterior 2/3 of septum, intraventricular septum, and PDA, posterior descending artery, supply posterior 2/3 of the intraventricular septum. You have been taught these things in anatomy, during anatomy, that is undergraduate level. So here we have bundles, left bundle, right bundle. So bundle supplied by anterior descending, not by the posterior descending. So in inferior MI, you will rarely get bundle branch block. If you get bundle branch block, that is right bundle branch block, but not left LBB. So if you get LBB, that is anterior descending occlusion, even it is right bundle branch block, most commonly it is anterior descending. Very rarely you got blood supply from posterior descending or right coronary. Did you get this point? Because ECG analysis, it is important. And we'll go to the next one. 35 years old man present to the ET with chest pain. Again chest pain. You can see most striking feature ST elevation in anterior territory. Complexes are broad. So if you see broad complexes, what are the differentials? VT, ventricular origin, bundle branch block, WPW, hyperkalemia. Right. So here complexes are broad. In sinus rhythm, probably maybe a bundle branch block. So look at V1. You can see tiny R and D pace. It is not RSR pattern like in right bundle. There's a broad R wave in V1 and the M pattern notched R in V6. So this is a left bundle branch block, anterior MI with left bundle branch block. So if you are not sure, there are some criteria to differentiate acute LBB in MI, that is Gabosa criteria. But so irrespective of right or left bundle, irrespective it is early or new, if patient come with chest pain, suggestive chest pain, patient need coronary intervention. That is the guideline. Right. So 35 years old man present to the ET with chest pain, 2 hours, associated with sweating. What is the most striking feature here? T inversions, those are also some sort of, locate into anterior territory, lead 1 AVL plus anterior territory. So these T inversions are some sort of significant T inversions. We call these T inversions arrow-headed T inversions. It's like arrowhead. So you get 2 type of ECG changes in non-STEMI. That is, one is this arrow-headed T inversions, another one ST depression with T inversions, where you get asymmetrical T. Right, this is non-ST elevated acute coronary syndrome. I am not telling this is non-STEMI. So to say non-STEMI, I have to mention about the troponin. So non-ST elevated acute coronary syndrome, it could be unstable angina or non-STEMI. Okay. So this patient, 65-year-old smoker, come with again pressure like chest discomfort lasting about 6 hours. He had type 2 diabetes, hypertension, physical examination unremarkable. When this ECG is taken, he is quite comfortable and pain-free. His troponin I negative. So patient came with chest pain. Now patient is pain-free. You have done CROP-I. CROP-I is negative, but ECG is like this. Is it normal? That's why very important to take the history. If history suggestive, now pain-free, what could it be? Yeah. Acute septal STEMI, Hawcom, Whelan syndrome, nodal bradycardia. So this ECG pattern is Whelan, that is T-wave syndrome, anterior descending artery, ADA T-wave syndrome, Whelan's type. Whelan syndromes, there are 2 types. One is this biphasic T, you can see here, and the other one, the symmetrical T inversions. So you get both type. So here there is a critical occlusion of left anterior descending. This patient initially need to be managed at non-STEMI, and patient need early coronary intervention, coronary angiogram early, because there is a critical occlusion of anterior descending. So we can't send this patient, need to admit and the treat at non-STEMI. Even the FOPA is negative, when the patient is pain-free, we have to revasculate. Otherwise, patient will come with again full-blown anterior STEMI. So 70 years old smoker with hypertension and diabetic mellitus come with sudden onset central chest pain. This is a ECG. What is the ECG diagnosis? Again, ECG is suggestive. If ECG is, chest pain is suggestive, so always you have to exclude acute coronary syndrome. What is this? You can see prominent T waves. What is these T waves? It's like hyperacute T waves or hyperkalemic T waves, very tall, and you can see upsloping ST depression in anterior territory. Anterior territory, you can see this nice tall T waves. So is there any syndrome like this? Yeah, hyperkalemia, D winter, anterior hyperacute T waves, posterior MI. So those are some differentials for this ECG. It is called D winter syndrome. So in D winter you get this ST depression, that is in this manner, with ST depression with hyperacute T in anterior territory. This is also a presentation of critical occlusion of anterior descending artery, where you need urgent coronary intervention, otherwise patient will get again massive anterior myocardial infarction. Unfortunately, we don't have this coronary facilities, PCI facilities. We have limited one. We don't have evidence to say we should thrombolize this one, but there are some article, because if we don't have facilities, sometimes some people have thrombolysis this, but here there is no proper occlusion. This is evolution, only the initial critical occlusion of anterior descending. Right. So this is also an interesting one. One day you will come across this ECG, I'm sure, because these are common thing. 34 years old man with bronchial asthma presented the ET with negative generalized pruritus, shortness of breath and chest pain following stop bite, was bite. On examination, patient is dyspneic and there is a generalized body swelling. His blood pressure 84/50. There is a diffuse bilateral bronchi on chest auscultation. ECG is like this. So this patient generally after was bite come in with like anaphylaxis, low blood pressure, pruritus, swelling, anaphylaxis. We have done ECG so like this. What is it? Any clue? It is not regular, right? When you see the lead 2 rhythm shift, it's like, it is not like regular, and you can say abnormal peace. The flutter waves in atrial fibrillation actually. When you see lead 2, lead 3 AVF, there is mild ST elevation. So this patient is having now inferior myocardial infarction complicated with atrial fibrillation, because SA not supplied by right coronary artery. If there is a ischemia to right coronary artery, so SA will not give the will not initiate the electrical activity. So then this patient can develop other atrial activities like atrial fibrillation, atrial ectopics, atrial flutter, like other, or even nodal. Right? So what is ECG diagnosis? What is the clinical diagnosis? Here, that's why I am telling that ECG diagnosis sometimes may be different from the clinical diagnosis. Patient come with allergic reaction, and ECG diagnosis actually STEMI complicated with atrial fibrillation. The clinical diagnosis Cooney syndrome, allergic myocardial infarction. One day you will come across these things. That's why I want to mention these things because here management, there are three types. One is due to acute coronary spasm due to allergic reaction, and the other one due to rupture of pre-existing atheromatous plaque during this allergic reaction, other one stent thrombosis. So there are there is a condition called Cooney syndrome. Patient presented with acute coronary syndrome with allergic reaction. So when you are assessing this patient, if a patient complaining of chest pain, it could be due to wheezing, difficulty in breathing, and even it could be a myocardial infarction. Right. So type 2 diabetic patient coming with this ECG and blood pressure is 70/30. One striking feature here, you can see ST elevation in lead 2, lead 3 AVF, that is inferior leads, and the reciprocal changes in lead 2, lead 1 AVL, suggestive of inferior MI. And the another thing, if you see a patient with inferior, MI, you have to see few different things. What are those? If patient comes with inferior MI, time is here. Time is 10 minutes. Okay. So if a patient comes with inferior MI, what else you have to see? So actually, if a patient comes with chest pain, you have to record ECG, not just 12 lead ECG, just because now we are going to exclude acute coronary syndrome. So please take order 12 lead ECG with V4R, because otherwise by the time you take the next ECG, the right ventricular involvement, infarction, so the ECG changes will be disappeared. So if you want to exclude acute coronary syndrome, please order a ECG, because it is very easy just to place that V4 in the other point, V4R. So here you can see V4R ST elevation. So the inferior MI, you have to see few different things. One thing, RV infarction, and sometimes I think you have seen enough ECGs with inferior and lateral MI, V5, V6, because right coronary artery, in 20% of population, 15 to 20% of population, right coronary supplies the lower lateral part of that is V5, V6 area of the left ventricle wall. And the other one, whether there is a posterior MI involvement, and other thing, whether there is a ischemia to SA node, pain and whether there is a ischemia to SA node leading to atrial arrhythmias. What sort of atrial arrhythmias? Atrial fibrillation and the atrial flutter, atrial ectopics, even atrial ectopics. And the other thing, ischemia to AV node, because right coronary artery supply 60% in population, right coronary supply AV node. So there may be ischemia to AV node leading to AV nodal dysfunction, and first degree heart block, second degree heart block, and the complete heart block. So this is ST elevation, acute inferior right ventricular stem possible. There is a possible posterior extension as well. So we'll go for next one. This 48 years old lady presented with again chest pain, burning chest pain. So here, what is the diagnosis? The most striking feature is ST depressions in V1 to V6. So chest pain, now you are going to exclude epigastric pain. Most of the people, I think in our region is presenting with the gastritic pain, right? Gastritis pain, the burning chest pain. So there are different type of chest pain coming with presence with the STEMI, constrict time, picking type, burning type, and sometimes some people asymptomatic, minority of people. So this is ST depression in anterior territory. So there are some conditions we consider as stem equivalent. What are those? Stem equivalent. Left or right branch block, irrespective of old or new. If patient presented with history suggestive of ischemia. Then I mentioned about the previous things, Balance syndrome, De Winter. So this is another one. And AVR ST elevation, the very first slide. Those are stem equivalent. So there's a ST depression from V1 to V6 and the gradual reduction of this ST depression. And if you take the posterior lead, you can see ST elevation in V7 to V9. So this is reciprocal changes of posterior STEMI in anterior leads. So if you see this sort of ECG, you have to take the posterior lead as well. This is posterior STEMI. Otherwise, you will miss this because these ST elevations are very transient. By the time you record the next one, you will not see this significant ST depression or posterior ST elevation. These are very transient. So this is posterior STEMI, and if you see 12-lead ECG with this ST depression in anterior territory, you have to consider it as it is STEMI equivalent. So this is isolated posterior myocardial infarction without RV. Without inferior territory involvement. So 42 years old man with neurofibromatosis coming with high blood pressure 252 by 130. So this is the ECG coming with palpitation, chest tightness, chest pain. There are some anterior ST elevations. So that's why I'm always telling that we have to clinically make the diagnosis. List 3 differentials for this chest pain here. High blood pressure, if a patient comes with high blood pressure and chest pain, first things to exclude it aortic dissection, otherwise you will thrombolize the patient with aortic dissection, that will progress. And so aortic dissection first one, because high blood pressure 250, 130, exclude it, get the history, proper history. By history you can get some clue. Another one, acute coronary syndrome, because hypertension is a factor for coronary acute ischemic heart disease. It causes the formation of atherosclerotic plaque, as well as high blood pressure causes rupture of atherosclerotic plaque. So that's why patient with hypertension, they come with STEMI. Another one, Takotsubo cardiomyopathy, I just want to mention about that as well. So catecholaminergic storm, secondary pheochromocytoma, this patient having pheochromocytoma can cause this sort of, it is cardiomyopathy, not due to coronary artery occlusion, but still this patient needs coronary angiogram to exclude coronary occlusion. So there are some specific features in echo to diagnose catecholamine storm, that is Takotsubo cardiomyopathy or broken heart syndrome, or sometimes we call that apical ballooning syndrome. You get a middle-aged female present with chest pain with during some stresses like funerals or whatever it is, during some stresses when there's a catecholamine surge, they come with chest pain. So still we have to manage this at acute coronary syndrome until we exclude this coronary occlusion. So there's an entity called MINOCA, myocardial infarction without coronary artery occlusion, MINOCA. So this goes into that group, MINOCA group without coronary artery occlusion. So the last slide, I think. So this patient, 44 years old man, present with the ETU with acute onset chest pain. ECG is this. What is this? if a patient comes with chest pain, always exclude acute coronary syndrome. This is, you can see anterior territory, very nice hyperacute T, broad-based T waves. So acute coronary syndrome, hyperacute T waves in anterior territory, we have to admit this patient to the emergency department and the monitor ECGs. If patient having chest pain, and then the patient will get the ST elevation, so you have to manage accordingly. So this is the difference between the hyperacute and hyperkalemic. The hyperkalemic T's are narrow based and tented. This hyperacute T's are broad and broad, tall T waves. So I am not going to these things. And today actually I was able to explain about the normal ECG and systematic approach in analyzing the difficult ECGs and analysis of ischemic ECGs. So if we have time, later we will discuss on these arrhythmias and so on. So I hope that you gain some knowledge of regarding and clues regarding the making diagnosis and managing the patient with chest pain actually. So sometimes, because these are life-saving, the acute life-saving diagnosis. If we miss this hyperacute TVV and if we are sending this patient, I have seen several cases, the patient, young patient especially, will come and with epigastric burning pain with gastritis, and treating for gastritis recently. I think that patient is still in the medical ward. I'm not, this is, I'm sharing our the experiences. Still that lady is in the ward, 44 or something. They initially came with and treated for the gastritis and later came with a STEMI. There is nothing, any fault in the our management, but we can miss easily these things. So that is life-saving. Patient can arrest, patient can die. That's okay. So thank you very much. Do you have any questions? No, I don't think so. Okay, thank you.
Step into the realm of knowledge. Empowering doctors, advancing excellence. Where innovation meets practice. Exploring the frontiers of medicine. The pulse of medical advancement. Elevating knowledge, inspiring excellence. Your gateway to medical mastery. Bridging science and humanity. Pioneering progress, shaping tomorrow. Redefining professionalism together. Mahiyanganaya Clinical Society, in collaboration with Government Medical Officers Association of Mahiyanganaya Branch, presents Academic Hour 2025.